Welcome to this presentation on TUDCA, Tauroursodeoxycholic acid. My videos on supplements are among my more popular ones. I usually highlight prebiotics in these supplement videos, but this time we're going to talk about a very interesting molecule and how it can play a role in your health. The T, or Tauro, in Tauroursodeoxycholic acid stands for taurine. That is the amino acid conjugated onto this bile acid. The U, or urso, stands for ursus, which is Latin for bear. It's heartbreaking for me to get into the disgusting ways that some of us humans treat animals, especially ones as wonderful as the bear. But sadly for these poor bears, this harvesting continues to this day in China, even though we have other means to produce the TUDCA, which has been used for centuries in China for fever, inflammation, pain, and particularly liver conditions. If you recall from my videos, the liver produces two primary bile acids, Ca and CDCA. All bile acids, to include these two, constitute about 50% of the organic component of bile. Once the primary bile acids enter the GI tract, over 50 chemically distinct secondary bile acids are produced by the microbiome. Bile acids affect the microbiome, and the microbiome affects the bile acids. One of these secondary, or in reality tertiary bile acids is TUDCA, or its conjugated form TUDCA, which is derived from CDCA. We're going to treat TUDCA and TUDCA as the same for this presentation, which they pretty much are, although TUDCA has some advantages over TUDCA. TUDCA has been shown to dissolve gallstones, treat cholestasis, biliary pancreatitis, primary cholangitis, non-alcoholic hepatitis, primary biliary cirrhosis, improve liver transplantation outcomes, inhibit cancer cell growth, improve damaged mitochondrial function, exert neuroprotective effects, and to date, TUDCA is the only drug approved by the US FDA for the treatment of primary biliary cirrhosis, now known as primary biliary cholangitis. As I've stated before, bile acids are critical in your health, especially within the microbiome, but certainly beyond. They are hormones and plug into a number of receptors, kicking off a slew of outcomes. They are not just simply a way to eliminate cholesterol and absorb fats and some other nutrients. Their role is far more complex, and by the time we're done here, hopefully you can appreciate that. For more information, see my videos on C. diff infections and liver health. Now, when we take antibiotics, the bacteria responsible for the conversion of primary bile acids to secondary bile acids tend to get killed off. This results in fewer secondary bile acids being passively absorbed in the colon and entering enterohepatic circulation. This is not a good thing. And this is one reason why antibiotic use is the #1 reason for a C. diff infection. One of the ways TUDCA is so beneficial is because it is very hydrophilic, more Latin for you, which literally means water-liking. We see here both TUDCA and TUDCA at the far end of the spectrum, whereas opposite it, we see conjugated forms of the primary bile acids Ca and CDCA. And we see the true bad actor in C. diff, Tauroursodeoxycholic. More on the hydrophilic benefits of TUDCA later. Now, before we hop into some data, we're going to touch on another mechanism by which TUDCA is beneficial, which is by means of what's called the endoplasmic reticulum, from now on ER. So this is a new term for those who have been following me. I don't like to throw too much at you at once, so we gradually introduce these things. So first, what in the world is the ER? So your cells constantly need to produce new proteins. A key way this is done is through the ER. The ER is both a biosynthetic powerhouse and a critical signaling organelle within the cell. It engages in extensive interactions with neighboring organelles, to including the mitochondria, phagosomes, endosomes, lysosomes, and the plasma membrane. The ER is responsible for maintaining calcium homeostasis, for the biosynthesis of phospholipids, and for the synthesis and folding of proteins that will be directed to the plasma membrane or to secretory vesicles. However, inflammation, nutrient deprivation, hypoxia, acidosis, and oxidative stress can disturb the homeostasis of the ER, leading to ER stress. ER stress is established when an imbalance occurs between the demand and the capacity of the ER for protein folding, resulting in the accumulation of misfolded or unfolded proteins. To normalize the ER homeostasis and reestablish protein folding, cells rely on a defense mechanism called the unfolded protein response, UPR. We see here, with many acronyms in this process, normal to the left and under stress to the right. So think of it this way, like making a ship in a bottle or a prefab building going out the door. The larger things assembled on one side need to fit through a bottle top or a door, and when on the other side need to be built correctly. If not, there are mechanisms in place to signal and tear apart what was built improperly. But if the levels of oxidation and inflammation are too high, think cardiovascular disease, neurodegenerative disease, metabolic disease, autoimmune disease, fibrotic disease, viral infections, and cancer, then the faulty construction exceeds the capacity to rectify the situation, which can result in cellular death. TUDCA, by some mechanism still not precisely known, has been shown in a mountain of studies to reduce oxidative stress, decrease inflammation, and suppress cellular death via the ER. Let's begin our disease state analysis with the classic use of TUDCA in the liver. As stated, TUDCA is the only drug approved by the US FDA for the treatment of primary biliary cholangitis, from now on PBC. Cholangiopathies are direct effects of hydrophobic bile acids on cell membrane, activation of autophagy, and induction of senescence, as well as induction of the ER stress and immune-mediated injury. So, if you were listening, we just touched on the hydrophilic and phobic nature of bile acids, as well as ER stress, which we just covered. It is established that the cytotoxicity of bile acids decreases with their increasing hydrophilicity, water liking, like TUDCA. In fact, the conjugation with taurine makes TUDCA more polar, which accounts for higher therapeutic effectiveness of TUDCA. Compared to TUDCA is better absorbed by the intestines and liver because of being fully ionized and water-soluble at various pH values. Recent multicenter randomized clinical trials have shown that TUDCA presents the same level of safety and tolerability as TUDCA for the treatment of primary biliary cholangitis, and may even be better to relieve symptoms of the disease. TUDCA normally comprises about 1 to 7% of the bile acids, and we see here 7.7%. Now, if you give TUDCA, some will be conjugated in the liver to TUDCA. If you give TUDCA, some percentage will be deconjugated by the microbiome to TUDCA. So again, for our purposes here, TUDCA is TUDCA and TUDCA is TUDCA. One is a drug and the other is a supplement. And as you can see here, over 1 year of TUDCA treatment resulted in a huge increase in the hydrophilic TUDCA with large respective decreases in the other hydrophobic bile acids. So clearly its administration changes the bile acid profile. And one end result is that the bile acid transporters, which are down-regulated in cholestasis, think sluggish liver or bile, are upregulated with TUDCA. Cholangiocytes are the epithelial cells lining the biliary tree. They are polarized cells that contain a significant amount of transport proteins that allow the secretion of large amounts of bicarbonate, water, and chloride that enrich the bile and contribute to regulate biliary pH, which is important for activation of pancreatic enzymes. Everyone is always taking enzymes. And the absorption of lipophilic organic compounds. Hydrophobic bile acids are strong detergents that can cause membrane disruption by lipid solubilization, while hydrophilic bile acids, like TUDCA, can stabilize cell membranes. Bicarbonate secretion has protective action against the detergent effects of hydrophobic bile acids. Treatment with hydrophilic bile acids induces bicarbonate secretion by several mechanisms. Hydrophilic bile acids can also inhibit apoptotic signaling pathways at the level of mitochondria or indirectly through anti-inflammatory effects by binding to the glucocorticoid receptor and counteracting the pro-inflammatory effects of bile acids. So let's take a look at TUDCA use in PBC. The aim of the study was to assess the association of TUDCA response and liver-related death or transplantation, hepatic decompensation, and hepatocellular carcinoma in patients with PBC cirrhosis. Of 501 subjects, 287 were TUDCA responders and 214 were partial responders. In general, when it comes to PBC, approximately 30% of subjects are only partial responders to TUDCA. Their data shows that TUDCA response is associated with a 51% reduction in death or transplantation and a greater magnitude, 60% reduction, in liver-related death or transplantation. The data also suggests that the benefit associated with TUDCA is greatest in patients with portal hypertension. These data also support a recommendation that TUDCA should be continued even after the development of advanced fibrosis. Now, why someone is a responder or not is uncertain, but this is for PBC. As you'll see, TUDCA has many more applications. To wrap up PBC, we have this study which performed a comparative analysis of the gut microbiome in PBC versus healthy controls, and had a subgroup of patients who underwent 6 months of TUDCA treatment. In Table 1, you can see significant improvements in liver function tests following TUDCA therapy. And they found a lot of classic microbial findings too. In A, you can see the significant differences in the abundance of genera between PBC subjects and healthy controls. The healthy controls had significantly more Faecalibacterium, no surprise for like the millionth time in my videos, as well as the health promoter Oscillospira. While the PBC subjects had significantly more R-specific pathogens, Klebsiella, Streptococcus, Veillonella, and members from the bad family Enterobacteriaceae, which we'll get into in a second. And also for the millionth time, we see your probiotic Lactobacillus lumped in with the bad actors. In B, the TUDCA treatment reduced Pseudomonas and Streptococcus, a good thing, and increased Oscillospira, also a good thing. And in C, we get back to the theme of response to PBC. Those with an inadequate response to TUDCA had significantly more Veillonella in their microbiome than those who responded. To return to Enterobacteriaceae, as I always say, it's the last family you want high amounts of in your microbiome. In this study, bacterial invasion of epithelial cells in PBC, sound familiar, like in the gut, no? Highly correlated with the abundance of bacteria belonging to Enterobacteriaceae. These members from the family of Enterobacteriaceae showed the strongest association with PBC and demonstrated a 6.4-fold increase in patients compared with controls. Upon closer examination, these species were Klebsiella pneumoniae, E. coli, and Enterobacter cloacae. E. coli, you know by now. Klebsiella pneumoniae, I often highlight. Here, Klebsiella displayed a positive correlation with serum levels of bilirubin, which is an important prognostic factor of PBC. In addition, Klebsiella species are associated with urinary tract infections. Of note, recurrent urinary tract infections are a risk factor for the development of PBC. And especially E. coli and K. pneumoniae have been found to be the most common bacteria that translocate into the mesenteric lymph nodes and liver and cause bacterial infection in patients with liver cirrhosis. This is in addition to the hours of videos I have highlighting across multiple disease states how these and other opportunistic pathogens drive disease. So you clearly don't want a high abundance of these guys in your microbiome. I hope you're enjoying the video so far. Don't forget to like, subscribe, and recommend to friends and family. Also, if you're feeling extra generous, hit the super thanks below. In this review, these authors looked at the beneficial effects of TUDCA in NAFLD, non-alcoholic fatty liver disease. NAFLD is considered the hepatic manifestation of metabolic syndrome, characterized by an accumulation of lipids in the liver and being strongly associated with insulin resistance, impaired glucose tolerance, type 2 diabetes, abdominal obesity, hypertriglyceridemia, and hypertension. Again, it's all connected. There is no drug approved for the treatment of NAFLD. Weight loss and dietary changes are standards of care. But if you read the quotes from this paper, if this natural compound were marketed as a drug, I'll bet it would make a fortune. Of course, we need to focus on the microbiome as well. More on that in my video on liver health. And if we take liver disease one step further beyond NAFLD, we get NASH, non-alcoholic steatohepatitis, which is characterized by an accumulation of triglycerides with the appearance of inflammatory infiltrate and cell apoptosis, cell death, with an evolution towards fibrosis and subsequently cirrhosis. In this review, of the 7 studies that solely used TUDCA, liver function significantly improved in 5 studies, and steatosis and fibrosis improved in 2 studies. And here is a long quote you can pause and read supporting several of the themes we've been highlighting. Now we'll switch over to the potential neurological benefits of TUDCA. Now we have to keep in mind that although I have a couple of human studies on ALS, the vast majority of this data is in vitro or animal data, with excellent results and supported by the biochemistry, but nevertheless, I should mention this in full disclosure. TUDCA can cross the blood-brain barrier, but it's not just TUDCA. All the bile acids can cross. In fact, more than 40 primary and secondary bile acids are found in the central nervous system, the CNS. The conjugated bile acids, such as TUDCA, have a larger structure and require active transportation through transmembrane transporters in order to have access to the CNS. The unconjugated bile acids, such as TUDCA, can cross the blood-brain barrier and enter the CNS by passive diffusion. The concentration of unconjugated bile acids in the CNS correlates with their concentration in the systemic circulation. Normally, the concentration of bile acids in the bloodstream is tightly regulated, although this does not speak to the mix of bile acids. However, say with liver issues, the concentration of bile acids in the blood may significantly increase, and depending on the type of bile acid, may damage lipid bilayers due to the detergent nature of the hydrophobic bile acids, causing damage and increases in permeability in the blood-brain barrier. TUDCA can interact with receptors on the surface of cells, such as the TGR5 receptor, which is essentially purely a bile acid receptor. And several of these receptors, to include the powerful TGR5, have been identified in the brain. Of course, TGR5 is not limited to the brain. It's also highly expressed in the GI tract, liver, gallbladder, and especially the spleen. So think about that. There is this one receptor with powerful effects within the cell that exists exclusively to receive signals from bile acids. And of course, once inside the cell, TUDCA can also activate nuclear receptors, such as the farnesoid X receptor, FXR, glucocorticoid receptor, and mineralocorticoid receptor, all with significant cellular impacts. One of those being on our previous topic, the ER, which is of note in neurological disease such as dementia, Parkinson's, and Huntington's, as these disorders share common crucial features: accumulation of protein aggregates in the brain. TUDCA doesn't just impact the ER within the CNS. It positively affects a long list of technical names like microglial cells, astrocytes, monocyte chemoattractant protein 1, vascular cell adhesion molecule 1, TGF-beta, and nuclear factor kappa beta. The net effect is a down-regulation of inflammation and the inflammatory response, which can lead to an improvement in neurological symptoms. I often mention much of what goes on is signaling, and this signaling can be driven by or drive inflammation. So, although the biochemistry is incredibly complex, the concept of triggers and inflammation is a simple one to grasp. Now let's take a look at those two ALS papers I mentioned earlier. Here from 2016, 34 ALS patients under treatment with the popularly approved compound riluzole, which the authors state, quote, "Thus far, only riluzole has shown a modest disease-modifying efficacy, as it prolongs survival by 3 months after 18 months of treatment. Unfortunately, the benefit is modest, leading to an increase in survival of perhaps 10 to 20%. Now, remember this for our next slide. So back to the study. These 34 patients were either given placebo or TUDCA at 2 grams per day for 54 weeks, in addition to the drug. The researchers looked for both symptomatic response, as measured in Figure 2, and survival, as seen in Figure 3. The proportion of responders was significantly higher under TUDCA, 87%, than under placebo, 43%. And the survival rate was better in the TUDCA group, although not significant. And here we have a similar trial in 86 ALS patients who were administered only TUDCA, as compared to twice that number who received the usual care. See the definition for usual care in the blue text box. The median overall survival was 49.6 months among those treated with TUDCA and 36.2 months in the usual care group, with a significantly reduced risk of death observed in patients exposed to a higher dosage, defined as equal or more than 1 gram per day of TUDCA, as compared to both the control/usual care group and those with the lower doses of TUDCA, defined as less than 1 gram a day. A gain of 13 months may not seem like much, but with what is possibly the worst neurological disease there is, it does show the impact of TUDCA in neurological health. In fact, TUDCA at more than 1 gram per day not only outperformed the usual care here, but it also outperformed the drug riluzole when looking at the data in its own package insert. Now that we've spent some time on how TUDCA can help with liver health and neurodegeneration, we'll touch on a mixed basket of health conditions. We begin with 2 slides on C. diff, the ultimate case of dysbiosis. Here we see significantly higher levels of the primary bile acid cholic acid in patients with recurrent CDI, a classic finding. And here we see significantly higher levels of the 2 main secondary bile acids, DCA and LCA, and the healthy FMT donors, and the recurrent CDI patients after FMT, more proof. And here we see the same. The patients after receiving their new healthy microbiomes had significantly higher levels of TUDCA than they did when they were on death's door with recurrent C. diff infections. In this in vitro C. diff study, the researchers found that in their screen of 20 bile acids, TUDCA was the most inhibitory against toxin-induced apoptosis, although TUDCA did not affect C. diff growth nor toxin activity in vitro, whereas TUDCA significantly reduced toxin activity, and TUDCA was the only unconjugated bile acid to not increase toxin-induced apoptosis, possibly due to its low hydrophobicity. They state that, quote, "We propose that the protection conferred by TUDCA observed in this work is most likely not specific to C. diff toxins, but rather the general anti-apoptotic activity of TUDCA can be leveraged against C. diff toxins." You can pause the video here and read these other quotes from the authors. And for more, watch my video on C. diff infections. If we look at SIBO, my most popular protocol, we see more benefit. I want to touch on 2 aspects from this paper. 1, I get a ton of questions on methane SIBO and can I help with it? Because SIBO patients, both methane and hydrogen cases, are frustrated from bouncing around from one practitioner to the next without success and don't want to waste any more time and money. I can understand that and I can help. So in this trial, the total methane gas levels were significantly decreased after 2 months compared with baseline in the TUDCA-treated group. And my second point is when it comes to stomach symptoms, which many people have, we see significant improvements in what's called the NDIK. The NDIK is based on 15 symptoms: epigastric pain, epigastric discomfort, epigastric soreness, chest soreness, stomach cramps, chest pain, early satiation, gastric acid reflux, postprandial fullness, epigastric pressure, upper abdominal bloating, nausea, belching, vomiting, and poor breathing. Do these sound familiar? I hear about them all the time in my consultations. And I fix SIBO from multiple angles at the same time. Not just with one thing like TUDCA, which is one of several tools of mine. Here we have a gallstone paper. Now, cholecystectomy, removal of your gallbladder, is the primary treatment option for symptomatic gallbladder stones. And TUDCA, or TUDCA therapy, is not even considered for reasons I won't get into. So these authors, who actually understand biochemistry, ran this study based on what a previous study showed, in that duodenal dysbiosis might contribute to common bile duct stone development. So what did they find? As far as outcomes, 62% of the evaluable patients treated with TUDCA responded to treatment, some with complete gallbladder stone resolution and some with partial dissolution. If we look at the fecal microbiome, we see some familiar names. The healthy controls had significantly more F. prausnitzii, Roseburia, and Lachnospira than the gallbladder patients. 3 names I mention all the time as health promoters. And as for another name I mention all the time as an opportunistic pathogen, Streptococcus, the gallbladder patients had significantly more than the healthy controls. And with the TUDCA therapy, Roseburia significantly increased in the gallbladder patients. Coincidences? I don't think so. And here we have a very similar study, this time looking at bile duct stones and the microbiome of the duodenum, which is the part of the small intestine just after the stomach. They did this because a number of authors suggest that bacteria might play a major role in the pathogenesis of gallstones, that the biliary tract microbiome is similar to the duodenal microbiome, and that retrograde infection from the duodenal microbiome could be the source of biliary infections. So what did they find? The genus Enterococcus was significantly more abundant in bile fluid in those with stones than the controls. Enterococcus is one of those classical opportunistic pathogens I mentioned all of the time. To wrap up the topic of stones, we have this review of 8 studies, which, by the way, does not include the previous 2 papers. One quote from this paper is, 7 of 8 studies were favorable of TUDCA for biliary pain, which is notable since I often hear in my consultations complaints of pain in the liver or gallbladder, or comments of sluggish bile. The authors conclude with, quote, TUDCA is an oral bile acid that reduces cholesterol secretion by lowering the cholesterol concentration of bile in the gallbladder. It dissolves gallstones and is licensed for use. However, due to the widespread adoption of laparoscopic cholecystectomy and lack of clinical awareness of its utility, the current use of TUDCA for symptomatic gallstones is uncertain. And lastly, here the authors compared the change in the microbiome composition after a 3-year intervention in a subset of colorectal cancer participants randomized to oral TUDCA or placebo. TUDCA drove a huge increase in F. prausnitzii, the superhero of the gut, and a huge decrease in R. navis, another classical opportunistic pathogen. They went on to state, quote, in men who received TUDCA, the overrepresentation of F. prausnitzii and underrepresentation of R. navis were more prominent in those with no adenoma recurrence at follow-up compared to men with recurrence. I think I presented a pretty comprehensive review of TUDCA. I often talk about bile acid dysmetabolism in my videos and how bile acids are actually powerful hormones, which plug into a number of cells within and outside of the GI tract. Bile acids, in my opinion, are certainly underappreciated, not only by conventional medicine, but also by natural/integrative/functional medicine practitioners. In every video, I provide perspective on the good and bad actors within the microbiome, which is incredibly consistent. Here, the effects of TUDCA on the microbiota are in line with all of my conclusions. All these pieces are part of a wider solution. If you think you have dysbiosis and gut permeability, I have to address the microbiome. If you think you have a sluggish liver, sluggish bile, and have excess fat in your stool, we have to address the bile acid metabolism. But remember, the microbiome affects the bile acids, and the bile acids affect the microbiome. Whether you suffer from metabolic syndrome, a neurological condition, or something else, I hope you're beginning to appreciate how it's all connected. I don't address one thing at a time. Like, for example, if you have SIBO or general dysbiosis, most everyone else is focused on bug killing, which may work temporarily, if at all. But to me, this is not very intelligent. I look at the whole picture, and depending on the person, TUDCA may play a role in regaining health. If you liked the video, don't forget to subscribe. Also, somewhere around here, you can go to my website where you can schedule a consultation with me. You can also view the protocols, and here, you can watch the next video.